On this episode of the ASC Podcast with John Goehle, we discuss the latest news, review recent developments in infection control under COVID-19 with Laurie Roderiques, discuss environmental cleaning, the use of outside cleaning services, how surveys are different under COVID, and review the vaccine program and discuss the use of N95 masks.
Welcome to the ASC Podcast with John Goehle, the longest-running podcast specifically focused on the freestanding ambulatory surgery industry. The ASC Podcast with John Goehle is brought to you through the generous support of our sponsors, Ambulatory Healthcare Strategies, Surgical Information Systems, Intalere, Encompass Healthcare Data Solutions, Medicus IT, and BHG Patient Lending. This podcast would not be possible without the support of our sponsors, all of whom have been carefully screened for the quality of their products and services and their dedication to the ASC industry. For more information about our sponsors, visit our website at ascpodcast.com and please consider them for your center's needs.
Happy holidays and welcome to episode 119 of the ASC Podcast with John Goehle for December 29th, 2020. We're recording from our studios in Spencerport, New York. This is Susan Cronkite, Chief Researcher for the ASC Podcast with John Goehle and Senior Nurse Consultant for Ambulatory Healthcare Strategies. Joining me is John Goehle, Chief Operating Officer and owner of AHS, recognized as one of the nation's leading experts in the ambulatory surgery industry.
And here we are stuck in the studio for yet another hour.
We're not stuck in the studio.
We just finished recording, doing live and then recording the update on the 2021 payment roll here with Christina Benton. And we knew we needed to get this episode out since we interviewed Laurie a couple days ago. So.
And you enjoy your time in front of the microphone.
I do, yeah. I like talking. So
don't try to convince us of anything else.
So I hope all of our listeners had a wonderful and joyous Christmas. We certainly did
Holiday time.
And we certainly had a nice time here. Very different, of course. I still didn't I've only been able to hold my granddaughter twice, but they wouldn't give her up the last time. Did you notice that?
She was sleeping soundly. It was just as well.
Yeah, it was probably best that way. But we had a lot of fun. I'm hoping everybody else has had some time off, and we're recording this just before the New Year's. So, and another thing to point out too is we're going to do New Year's Eve. It won't be posted probably until New Year's Day, but we're going to do a final episode for the year, which is be a retrospective on 2020. We're going to look back on.
Do we have to talk about 2020?
Well,
can we just let it fade away?
I think what I want to do is talk about some of the things that we've learned and things that are going to be. We talk about a little bit on this episode is what's the permanent change that we're seeing, but really to try to make some predictions for next year. We're going to start doing that. We're going to try to predict what's going to happen next year and see how how absolutely wrong we can be.
Yes, but you are right. There are so many things that have changed in 2020, obviously, but a lot of them may be permanent changes, and some maybe for the better. We've learned some lessons, and
I believe there actually has been some very positive things that came out of it, and it's time for us to start recognizing that. And also, some changes coming up for the ASC Podcast with John Goehle, and the some of the exciting things that we have heading into the new year with new conferences. So suffice to say, our audience is going to have to get used to conferences virtually here. We're getting very good at it. We're getting a lot of good feedback on it, and people are attending in larger and larger numbers. And our audience for the ASC Podcast is increasing pretty significantly here. So I just want to thank all of our loyal listeners for this past year. You've made this obviously the most popular and the only podcast in the ASC business. So, and to that end, if you are CASC certified, if you're a certified ambulatory surgery administrator and you're short on your AEUs, don't forget you can get AEU credit for listening to the podcast. So go to the website at ascpodcast.com and follow the links for AEUs. And of course, I'm not going to give you a heck of a lot of time to do that if you want to get the hours in for 2020, given when this is probably going to be posted. But do it quickly, and you should be able to fill out the rest of those AEUs. And of course, all of our conferences, almost all of our conferences, give AEU credits too. So definitely think about that. So, Sue, it's been a busy week with news. Do you want to, of course, the biggest news right now, of course, is the vaccine. So why don't you talk about some of the stuff you've been working on very hard with the vaccines?
Okay. And actually, this vaccine requirement that we're going to talk about really has to do more with vaccines that we've been using for a while, flu vaccines and that type of thing. We don't know enough about giving out the COVID vaccine or the recommendations to really have come up with anything for that.
Other than knowing that it's at least going to require the same things that a vaccine would, but there'll be other stuff. Yeah.
Yes, it's going to take some thinking. So AAHC Chapter 11 requirement that has recently come up in some surveys is for documentation that you're following the nationally recognized guidelines for vaccine storage and handling, which would include policies, adoption by the governing body, and staff education. So a requirement in the CDC guidelines, which is one of the nationally recognized guidelines, is to maintain a vaccine inventory log. And we'll discuss the specifics when we talk to Laurie a little bit later. We'll share that interview and discuss the things that you should have on that.
And we will share in those that are members of the ASC Podcast patron program have access to our database, which includes or will include, some of these new forms that are being developed right now. Yeah. So definitely take a look at that.
And in the New York Post yesterday, they reported on a healthcare company in Brooklyn that's being investigated on allegations of not following the appropriate guidelines regarding obtaining and administering the COVID-19 vaccine. And as we've talked about, there's just going to be so many legal implications on all of these COVID-related issues, I think, as we move forward. So the Health Department Commissioner, Howard Zucker, stated that, and I won't say the name of the center, but that Brooklyn healthcare company.
And it's not an ASC, by the way. It's important to note. It's a healthcare organization, but it's still very relevant to us.
Yep.
I'm sorry. Go ahead.
That's okay. That they, and I'll quote, may have fraudulently obtained COVID-19 vaccine, transferred it to facilities in other parts of the state, which is in violation of state guidelines, and diverted it to members of the public. So the facility said that it did follow the guidelines and that it was approved. Now, Governor Cuomo has said that he plans to sign an executive order that will establish a $1 million fine for vaccine-related fraud and can include revocation of state licenses for doctors or nurses who violate the rules. He said even patients can be charged if they knowingly receive a vaccine they're not, yet due for. So basically, they're jumping the line. So, they're really watching things. So even if, I guess I just wanted to point this out because even when you feel like you're doing the right thing, just be very, very careful. Make sure that you really know what you're doing and that you're following all the guidelines.
Well, and my concern has been all along that it's just way too easy for, let's say, that you get a hold of a batch of vaccine and you give it out to your patients or to your employees, and then you have some left over and you say, hey, wait a minute, let's offer it to the family members also. And it sounds like a good thing. It sounds like you're being
you have an
nice.
Older mother or something like that, and you think, well, you don't want to waste the vaccine, but you've just got to be very careful.
You do. And one of the reasons that I'm concerned that we might not be anywhere close to the first on the list to get the vaccines in the average surgery center simply because, we wouldn't be able to assure that we can give away all the doses to people that are appropriately that fall into those categories. So definitely be very careful about all of that and recognize that, $1 million fine is a significant amount of money.
And losing your license.
And losing your license for doing that. And then the facts that the person receiving the vaccine can also be charged.
If they know that they're,
if they jumped the
what
line.
They were doing. And I think, this is probably a good time to mention, I know a lot of centers have been asking what we know about the timing for receiving vaccines. And, we're still kind of waiting. I did see something that said, at least in New York, I think next week, ambulatory
healthcare centers,
but I don't know how that's going to work, where you're going to get them from. It's all still just kind of a waiting game.
And then on December 10th, 2020, the Department of Health and Human Services Office for Civil Rights issued a Notice of Proposed Rulemaking that's also known as NPRM. So I'm going to use that initials in the future. Notice of Proposed Rulemaking, proposing some changes to the standards under the HIPAA privacy rule. So this is the first kind of major change since the high-tech rule came out. This notice of proposed rulemaking would make several changes to the individual's privacy rule regarding the right to inspect and obtain copies of their protected health information maintained in a designated record. So here's just a kind of a brief outline of the change. I don't want to go into a lot of details on it, but I just want to kind of keep people aware of it. And again, this is proposed. It isn't finalized yet, but be prepared for yet another change. And of course, this will, of course, require you to change your notice of privacy practices, just like we did when high-tech came out. So it would allow individuals to take notes, videos, and photographs when inspecting their health information. So if you give them access to their medical record, now they can take a copy of it. They can do a video of it. They can take notes while they're doing it. In the past, that wasn't always allowed.
So does that mean they wouldn't have to pay for copies? They could just look at it and snap a picture? And maybe you don't know.
Question.
I don't know what
I never even thought about that. Leave it up to the documentation nurse to think about it. I never really went that far, but you're probably right. Yeah, because you can't charge for them to look at it, but you can charge them for making copies. It limits and clarifies the fees that covered entities may charge for providing access to individuals, because as we all know, that hadn't always been very well set forth. Requires healthcare providers to allow patients to review their private health information when it is available at the point of care in conjunction. This would be like during a healthcare appointment. So instead of saying to them, well, you can come in 30 days and get access to it, if it's in the record and it's immediately available and they're there for an appointment anyway, they're proposing that patient be allowed to see that. That could really disrupt.
Yeah, that's what I'm thinking. The timeline of that, if they decide, I really want to look through my medical record, because you can't just hand it to them and walk away.
Right. I guess the best example would be somebody coming back for a GI procedure or a pain procedure. I think it would probably happen a lot with pain procedures, for example, where people come in and, they say, hey, while I'm here, can I look at my medical record? And this kind of implies that, as long as they have the proper authorization, they can get to do that. As you can see, we're kind of critical about this because, it complicates an already very complicated situation. It would reduce the time frame for providing access to PHI from 30 to 15 days. Now, that's probably not terribly unreasonable. I think that 30 days always was a lot anyway. Require patients to sign a specific HIPAA authorization before sending certain non-electronic PHI or electronic EHI outside of an electronic health information directly to a third party. So this is actually a good thing. So in lieu of relying on the HIPAA right to access provisions under HIPAA, now they're going to have to fill out a form to do that. So I think that's a positive step. And then lastly, of the things that we picked out from it, require healthcare providers to transmit an electronic copy of PHI in an electronic health information directly to the healthcare provider or health plan designated by the individual. Now, that's going to be interesting for us because, of course, there's that whole communication issue. In other words, how do are our systems compatible with those other systems? Are they? I can't imagine you can't send them by regular email. So I don't know what that means. And of course, that's kind of the whole point here is that this is just the beginning of the process, and hopefully we'll hear about it soon. More about this soon. I better say the next one because we were just laughing about this. So the Medicare fee for service claims, the sequestration has been suspended. So so in 2012, the government instituted a 2% payment reduction referred to as a sequestration. It is a temporary sequestration or temporary suspension, a temporary reduction in the fees. So now Medicare has temporarily suspended the sequestration. So that's kind of like a double negative there, Sue. We were kind of laughing about that earlier, is that they have temporarily suspended the temporary reduction in your reimbursement rate. The easier way, of course, if people like you and I who, try to make things simpler in our lives did it, we would just stop the sequestration because it was temporary anyway. But no, they decided to suspend the temporary reduction. So what this means is that 2% reduction that you saw in all of your EOBs for Medicare fee-for-service claims is no longer going to be there. Now, interestingly, about 2 hours ago, we were on we were doing a live conference where one of the listeners said that they still see the sequestration reimbursement cut in their EOB, the explanation of benefits. Which we were surprised. All of us that were on the panel were kind of surprised at. So we encouraged them to go back. So here's the interesting thing. Check your EOBs to make sure that the EOBs, since I can't remember when the reduction started, but make sure that sequestration does not show up at the bottom of your EOB now, since it's on suspension. Now, this goes through, March 31st, and then in March 31st, unless it is reenacted, I don't even want to think about how you would figure this out. But at least until then, you should not be having that 2% reduction in your fee.
And we want to remind you, don't forget the requirement that the ASC must periodically provide the local hospital with written notice of its operations and patient population served.
So that phrase comes directly out of the revised conditions for coverage. I just copied and pasted it right in there.
Okay, so it doesn't specify a time frame, just says periodically. And remember, this is a local hospital, so it may not be the hospital that you normally have a relationship with, but
like a transfer agreement with, right? So that's a very important point, is that many of you have had to, go to a hospital that isn't necessarily the closest hospital. So that whole sentence leaves a lot for interpretation. So the best thing I can do is say that, again, the sentence says the ASC must periodically, it doesn't say how frequently. I would interpret that probably as at least once a year.
I would think, yeah.
They must periodically provide the local hospital. So that's another question. What is a local hospital? I would assume that would be the hospitals that are closest to the surgery center, with written notice of its operations. So what is the written, what do they mean by operations? We kind of assume that, and the patient population served, we kind of assume that, I'm a GI center.
The type of, procedures that does. And this kind of takes the place of
a transfer agreement.
The transfer agreement.
Yeah. The purpose behind this is that CMS did remove the requirement that you have a transfer agreement in place for your ASC. Now, that doesn't mean that the state might not require it. For example, Ohio requires you to have a transfer agreement. Other states like New York doesn't really require you to have a transfer agreement. There's other requirements regarding hospitals, but they don't specifically require you to have a transfer agreement. So regardless of whether you have a transfer agreement or not, you still have to do this reporting. We are working on a form, which again, we'll post on our Patreon page when we finally get it ready, so that people can use that form to report. And the nice thing about that form is that you'll be able to, just kind of keep a copy of it and then send it out every 12 months or whenever you feel like it.
So now let's talk about some recent experiences that you've had and how they apply to everybody.
So some of them are kind of interesting.
You always love a good story.
I know, I always love good stories. So, some of our inspections or our surveys recently have focused on the annual door inspections. And Alex Borneman, who's Director of Operations and our certified NFPA certified person. I mean, we also have Jim Masters, who is our surveyor, who also has got a lot of background in life safety. But Alex kind of pointed out that those annual door inspections need to be done on an annual basis, and it needs to go through all of your fire doors. So you can't forget about them, because the surveyors are asking about this. So when they come out, they're going to want to see that annual door inspection. Now, you need someone to do those door inspections who has been trained on performing them. There is some controversy about what they mean by training. So there are some people that interpret that you have to have like a professional door inspector come in. That is not true. But you do need to have somebody that's trained on how to perform those. Now, for example, in our company, Alex has been trained on how to do it, and he trains other people on how to do these door inspections. And by the way, Sue, we are going to we're going to record a training session for that and make that available. So he's actually this is how exciting his life is. He's going around taking pictures of doors and damaged doors to give an explanation of what you would be looking for. I mean, it's actually kind of interesting.
Yeah, you want to be able to really see it.
Yeah, and I've been trained on how to do it too. It's been interesting. I've been lucky in the places that I've gone into have been like new construction. It's been very easy. There's really been no door damage. But Alex has had to inspect a couple places that have had really some significant damage. It's not difficult to have damaged doors, but a damaged door on the firewall impedes its ability to be a fire protective barrier. So that's why this is important. So your surveyors will be asking to look at this. We're going to be providing you some resources for training on it. And let's not forget that you have to do it on an annual basis. And the thing that I learned today was that so we just had a survey today for a pre-open, or not a pre-opening, but a early option survey for a center that opened today. By the way, they passed with flying colors. We have been, the last two surveys, we've had two early option surveys in the last week, and both of our clients, we are so proud of them. They have just the administrators there, the nurse managers, they did an incredible job, and I am so incredibly proud of them. The survey went really flawlessly. But one thing that came up during one of them is that the door inspection hadn't been done, and we were not aware that, even after the initial installation of the door, somebody still has to go through and inspect it. So even though there was proof that the door was installed according to the manufacturer's specification, we still need to have a door inspection to prove that it's been looked at. So we did not know that. Now we do. Lots of issues with computer systems recently. We've talked about this before, but I do really want to focus on this. Now, I mean, in all fairness, full disclosure here, of course, one of the sponsors of the ASC podcast is SIS, Surgical Information Systems. And of course, we love their system. We love the people there. Ann Geyer is one of our closest friends. And there's a lot of other good systems out there. But here's the problem that we've been running into lately, is I'm seeing a lot of new centers being constructed and using or imagining that they can use the computer system that they might have in their office for their surgery center. And the problem that they're running into is the inability for that system to generate required reports that you would need for ongoing operations. For example, I'll just give you one example. Two. You need to have some type of an inventory management system, but most systems that have been designed for an office don't have that capability. And so inventory management is really critical to be able to, have a list of all of the supplies that you need for a procedure. A pick list, shall we say, is something that's critical to have built into a system. Another thing that you really need to have is the ability to print out a list of all the procedures to send to each of the doctors to be able to do your infection control survey every month or every 3 months, depending upon your situation. So I just really want to emphasize the importance of making sure your owners understand that when you're looking for a computer system, you really need to focus on something that has been designed for the ASC industry. And the good news on that front is you're not talking about a system necessarily that is significantly more expensive than what you already have available to you. It would be cheaper than, just adapting your existing system, but then you've got some significant issues also with regard to, the HIPAA separation of the two operations. So enough said about that. I don't want to overemphasize it, but just be very careful, especially as we go into the new year and you start thinking about your capital budget. Maybe it's time to replace your computer system, or heaven forbid, you're thinking about getting an EMR system that's not been designed for an ASC. Trust me, you're going to run into a lot of issues there.
And another thing that we've run into a lot is, which is not a new thing, lots of turnover.
A better way of saying it is that continuing problems with turnover.
Yep. I think just worse because people are either afraid of getting sick, people are, retiring. So really important, keep your leadership happy.
Yeah.
Keep everybody as happy as you can, It's just much easier to keep people there than to try to train somebody new.
Yeah, and what I meant by I wrote that line there, keeping your leadership happy. So I'm really speaking out to the to the owners about making sure they keep their nurse manager and their administrator happy, and to the administrator and the nurse manager. What happens if you lose your charge nurses, the people under you? I'm sorry to interrupt, but that really, I'm not meaning to, those are the only people.
No,
everybody has to be kept happy down the line. So.
Yeah, but the more, it all kind of flows down, I think, is what you're you're saying too. And, if you do get in the position where you have to hire somebody, just be very careful who you're hiring. Don't hire the first person that comes to you with a resume that mentions ASCs. It is important to look for somebody that's familiar with the ASC environment.
It's been frustrating.
As opposed to a hospital, but
we've done a couple interviews recently for people. So the owners will come back to me and say, hey, I got this great candidate. They've worked in an ASC before and they've worked with HHC. Well, you do an interview and you find out that this person worked in an ASC, but they were, a nurse on the floor. And they were there during the day that the ASC was surveyed by HHC. They had no involvement with that. Or I had another issue recently where there was an administrator of a surgery center who was an administrator because he was the practice manager. And he had a nurse manager that ran the surgery, really ran the surgery center. He just, was her boss. And he knew nothing about quality improvement, knew nothing about the HHC survey other than he was there for the exit conference, and really didn't have any day-to-day responsibilities. And I said, we can train them to become a good administrator, but don't walk in there assuming that you can give them all these responsibilities. Yeah. And that just gets to another point that you and I are passionate about, because we have to deal with the mentoring of new administrators, new nurse managers, literally all the time, is that this is not something you learn. You certainly don't learn it in a week. You certainly don't learn it in a month. Yeah. You might start to get proficient within 3 months, but it takes a year. And trust me, I am not just saying this.
And they have to be able to devote their time to that. So, you may have a lot of different responsibilities that you need this person to be able to handle, but you really have to allow at the beginning for them some growing time just to be able to figure out everything that they need to do. And I also think a lot of it is just paying attention to their attitude and their energy level, maybe when you're interviewing them, because if somebody comes in and they may sound like they know everything, but if they're not willing to take direction from you or they're too confident, I feel like that's almost worse than if somebody comes in and, hey, I don't have this experience in these certain areas, but, I'm always willing to, grow into the role, and I'm, I love a challenge or whatever, and they're willing to learn and really put a lot of themselves into this.
Well, and let me give 2 examples too. You didn't do that interview with me. Well, I did an interview a couple days ago, 2 candidates. And the first one came from a women's health center, and actually ran a women's health center that was more of a clinic. It wasn't an ASC. And she had been in women's health her entire career. And I'm sure she was great at it. But she ran a clinic, and she felt that she was ready to run an ASC. And there was 2 problems with this particular situation, is that it's an ambulatory surgery center, so it has, state licensure, federal certification, and accreditation. She only had experience on, the state licensure side, none of the other experience. And then second is that she had been in women's health all along, which, by the way, is a very important specialty, and there's a lot of specialized knowledge, but so does orthopedics. And the center that she was applying for a job in was orthopedics. Making a switch from women's health to orthopedics would be a huge sea change. And again, not minimizing at all the incredible knowledge base that she had. As a matter of fact, if she were going to work for a surgery center that did women's health, I would actually be ready to say, yeah, she can probably do it. But what disappointed me, so one of the questions I asked her in the interview, and maybe this will give some advice on interview techniques, is what do you think, what types of resources are you going to need to transition in orthopedics, and what do you think some of your challenges will be? And she says, well, I'm very experienced in healthcare, and I learn fast, and I'm sure that it won't be that much of a difficult. And the second case, so that really kind of turned me off to her, because she wasn't admitting that she was going to need help. If she had just admitted it, she would have, gotten my interest a lot more. Then the second candidate came through, and unfortunately, he didn't have experience in orthopedics either. And he had some other issues which might make him might not make him a good candidate. But when I asked him that same question, he said, John, I got to tell you, the big thing is I know what I don't know at this point. And I don't know how I'm going to get that knowledge. And, I said, look at me. It's like, that's what we do as a company, is that we, the company that you've applied to has already hired us to do that. We can do that. And he said, then that's great. Then that's what I'll do. I don't know what I don't know. And I said at that point, something that's the best answer I've received in an interview for a long time. So 2 pieces of advice. So first of all, if you're searching for a job, at another surgery center. First of all, call me, because we have a lot of opportunities right now in surgery centers in New York, at least. And
there's a balance between, I think, selling yourself and sounding overconfident. And we've had experiences with people that are more interested in proving their knowledge than they are willing to take advice. So you end up just bumping heads the whole time, and you don't get anywhere.
Yeah, that's well said. That's well said. So just some advice there. And another thing I just kind of want to talk about, and I'm probably getting into some trouble for this, is One point I really do want to emphasize, just because the place they work for was accredited doesn't mean that individual that you're hiring has knowledge about how to handle a survey. That's a completely different skill set. Yeah. I did want to mention a couple things that we've run into, where to get candidates and where not to get candidates. And I hate to say this, and please don't take any offense, anybody that's listening that come from these backgrounds, but you have to be very careful about hiring people that come from a hospital. Especially those that have been at the hospital for a long period of time, because it's a very different skill set in the hospital. They don't run as quickly as we do. There's a lot of additional services there. As I tell nurse managers that are transitioning from, being a nurse manager on a floor in a hospital to a surgery center, it says when you hit that code button, you don't get a code team showing up like you do in a hospital. You get it's you responding to it.
Thing is, most people do start at a hospital, so
that's not my point. Yeah, what I mean is that it's tough to go from a leadership position in a hospital into a higher leadership position in a surgery center. So thank you for correcting me on that, because definitely, as a matter of fact, Jenna came from a hospital environment. Yeah. My daughter and one of our senior nurse consultants, and she transitioned well, but it's not like she came in thinking that she could run a surgery center, coming directly from
try to get somebody moving up the ranks.
You've got to just like you did in the hospital, you had to learn, the ropes. You're going to need a little bit of time in the surgery center. So to be very careful about hiring people in high leadership positions. Now, they might make a very good charge nurse, as a matter of fact, but to be able to be a director of nursing coming from a floor in a hospital, that's going to be a bit of a transition. And another thing, it does happen, and again, I have a lot of very dear friends that are practice managers out there, but a practice manager going from running a practice, which is a very complex operation. As a matter of fact, I find a good practice manager and a good ASC administrator, are at the same level. I mean, they need the same level of expertise. And I do think in some ways it takes longer to become a good practice manager than it does to become an ASC administrator, because as a practice manager, there's many other factors that you have to, and you often have larger staffs in larger organizations. So it's a tough job, but that doesn't mean that you become a good ASC manager, because whereas a practice manager is much more focused on, the schedule and managing the people and the revenue cycle and expenses. In a surgery center, you've got that whole regulatory thing. So if you're going to put a practice manager in the position of running a surgery center, they've got to learn about licensure, certification, accreditation, and that's a lot to swallow. So again, moving them into that role at a lower level and then moving up the ranks, that certainly works. But putting them as a practice manager into an ASC setting can be a very difficult transaction. And again, I'm going to say this again. It takes a good year for someone to settle into a new position, either as a nurse manager or an administrator. Give them that time. And Sue, you said it earlier too. And don't think that they can spend 75% of their time in the operating room and then 25% of the time doing administration. That is not an appropriate split of time.
Yeah. So where do you look for somebody?
Well,
I hate to tell you what not to do and not tell you what to do.
That's it. And she's always calling me on the carpet for this. So I do believe, hiring from within is very important. We joke about I often ask the question, how many of you, went home on Friday and then Monday morning found out you're the new administrator and the new surgery nurse manager, because so many people got into that position that way. And that's not ideal, but it's better than going out and hiring somebody that doesn't know anything about it and then giving them good resources. So the answer to that, I think, is look for people in your organization that have a bright future. And of course, this is sometimes tough, because hiring somebody that might eventually become your successor can be difficult to do. I have no problem, because I want to retire at some point and I'm looking for a successor here. But, not everybody feels that way, especially if they're relatively young. But, a good leader is somebody that is always looking for somebody else, because eventually you're probably you might want to move on. Maybe, you're the administrator for a 2-room operating, facility in upstate New York, and you hate the winters, and you want to move to a 4-room, bigger facility down in South Carolina where it's not, nicer weather, as long as you're not on the ocean, and during hurricanes. And that's your dream. So, if you're going to do a great job, you should be and know that's where you want to be eventually. Find somebody in your organization that you can start mentoring into that position. And I think, and it's, you're going to do a service for, good service for the organization. Your owners are going to appreciate that. You can rest well at night knowing that, if something happens in your family and you can't be at work, for a day or a week or a month or a year, somebody's there is going to keep it going. And your owners will be appreciative of the fact that you thought that far ahead. So to your point, I think the best people are those that you grow into the job, within your own organization.
And I think along those lines, I always try to identify people that have an interest in different areas.
Yeah.
And that have that respect of the other staff and that have, the motivation to do things. Because even when you're hiring somebody to take on a larger role, the more people that can kind of help out, and this person is, does infection surveillance, somebody else, handles a different role. I think that just often when people are really overwhelmed by things when they start in that position, it's because they're kind of expected to do it all.
Right.
And there's really no reason why one person should have to do all of that.
That's right. And to that end, try to identify I remember in both the surgery centers that I started myself, we identified nurses who would take on, one person would be in charge of employee health, for example. One person would handle all the employee health records. Another person would be in charge of education, would be doing the orientation, mandatory education. Another person would be doing the chart audits. Another person would be in charge of infection control. Now, that didn't mean that the nurse manager didn't have anything to do. Trust me. I mean, just even coordinating those 4 positions we just talked about is a job.
And they can just be assisting in it as well. And also then you've got some backup. If somebody unexpectedly has to leave, you've got some people that at least have a passing knowledge of that.
Yeah, I guess I want to mention, I might have mentioned this in an earlier podcast, but about 3 weeks ago, I did a survey of an organization, and I showed up with a survey team. There's 3 of us. And when I showed up at the reception desk, they said, well, the administrator's not here. I said, that's fine. Can we see the nurse manager? Well, she's not here either. It says, is anybody here in leadership? She says, no. And it's like the 3 of us on the team looked at each other and said, like, who's in charge right now? And of course, we're talking to a receptionist. The poor woman was like, she wasn't frightened. It's just that she didn't have the answers. We sat there for 45 minutes. I literally dialed the main office for the accrediting organization, and I was about to tell them that nobody had shown up to let us in, because the rule of thumb is that you need to get in within 15 to 20 minutes. So, of course, we're all sitting back there. The survey team is suspicious that they're running around doing something that, to clean up. We didn't believe them when they said that there was no leadership there. So the first question we asked is like, who's in charge when you guys are not here? Now, they did very well on the survey overall, but it meant that we looked a lot harder. And what we did find is that, it was a tough day. And I mean, there's, during COVID, you have to give exceptions for everything. And we understood what was going on. But still, by the way, never let your survey team wait that long, because we're actually
to be grumpy.
Yeah, that's right. Because we're already writing up a list of all the additional things that we're going to need, right? And to that point, that's actually a good point, Sue, is that what I've always said to people, if the administrator is 30 minutes out, if you can't get anybody in right away, and like we live in upstate New York, the reasons for that could very well be that, they just couldn't get there, their car broke down, they had to take their kids to school, whatever. The first thing you do is always have a backup plan. You say, can I put you in our conference room, and I'm going to give you your policies and procedures to get you started here. Here's the schedule. At least give the authority to somebody in that organization to get them started and say, I am so sorry. This is just so unusual. You caught us off guard. I mean, we're running, well right now. It's just, it happens to, be a difficult day for us. And those things happen, there are days that things don't go quite right. Unfortunately, nowadays under COVID, that's pretty much every day. Yeah. But I didn't feel like they had a plan for dealing with us. And then, they made it worse by when the people did show up, they kind of said, well, we didn't expect you today. Well, you need to be expecting a surveyor any day. That's not a good answer to that. So. Okay, we have an exciting. You and I 2 days ago recorded this great interview with Laurie, and I remember telling you halfway through the interview, Sue, I want to drag this out for an hour so that we can get one IPCH unit. In other words, the infection control continuing education credit. And we said, okay, yeah, we can do that. Well, when we looked down at the clock, the interview had already been going on for an hour and 15 minutes. Now, you did, by the way, I did check it. It's an hour and 4 minutes. So it is still a long interview. I cut a lot out. But it was a great interview. A lot, of course, Laurie is just an incredible wealth of information. And I think you're going to enjoy, listening to her. And we are going to do a session shortly with her, kind of focusing on infection control specifically. That will be available also for your for in-services for your staff. So let's take a short break and we'll come back and we'll interview Laurie Roderiques, Director of Clinical Service for Ambulatory Healthcare Strategies.
Is your ASC meeting all the infection control requirements in the new normal? Let the team of experts at Ambulatory Healthcare Strategies and the ASC Podcast with John Goehle help you be prepared for the new normal with a range of resources. Be prepared for the infection control challenges of your ASC. Our resources include our free podcast. We'll be adding content to help keep you apprised of the changes and the requirements for infection control. And of course, the podcast is always free.
And the ASC Podcast now has the industry's leading education program for infection control coordinators, which we refer to as the ASC Infection Control Coordinator Training 2020. And we'll be updating this every year, but this training is available at the ASCpodcast.com website. This is a recording of the training program to prepare nurses for the role as an infection control prevention coordinator, or to improve the skills of coordinators that already have that position in the ASC setting. And it was recorded on April 7, 2020. This is a full-day course focused both on the basic skills necessary to become an infection control coordinator and to build on skills that current coordinators already have. Particular emphasis is placed on the infection control challenges of our current environment and preparing for more rigorous surveys in the near future.
After completing the program, attendees will receive a certificate demonstrating that they received the training. The cost of the training is $199.99, and you can get more information about it at the ASCpodcast.com website.
Ambulatory Healthcare Strategy now offers ongoing retainer-based infection control oversight, which includes an annual infection control mock survey, or more frequently, if you wish, review and revisions to your infection control program annually and as needed, annual competencies for your staff on infection control, and that's done during the mock survey, annual training on infection control, also done during this survey, and that's designed for your staff, assistance in investigations of any infections that you might have, assistance in preparing your annual infection control risk assessment, and of course access to all of the AHS infection control resources that our clients have come to rely on.
And for more information on our retainers, visit the Ambulatory Healthcare Strategies website at ah-strategies.com or call John Goehle at 585-594-1167.
So this is John and Sue, and we're here with Laurie Roderiques, who's the Director of Clinical Services for Ambulatory Healthcare Strategies, and we are recording the day after Christmas. Why are we recording the day after Christmas, Laurie?
Because we can.
So did you have a good Christmas?
Oh, it was it was lovely. How about you?
Same here. The puppy, Santa Claus did visit the puppy extensively. And Santa Claus gave me one of those Furbos. Well, it wasn't really Santa Claus. I know now that it was Sue, but
yes, he figured it out.
I figured it out. So now with this Furbo is one of these treat throwing things that you hook it up and then you can see your dog from anywhere in the world, and then you push this button and you can throw a treat at her.
The first one was kind of funny because she had her face right up against the mechanism thing because she was talking through it, saying, "Hey, Rosie," and then all of a sudden, bing!
Got her right between the eyes.
But then she figured it out when that sound comes. Yeah. There's treats coming.
So we're having a little bit of fun with that.
And it's going to be all chewed up, you realize.
So, well, Laurie, I have an interesting story for you. I was talking to one of our loyal listeners, and they said, "Oh my goodness, I just love Laurie. I love the way she picks on you all the time when we do podcasts and those virtual conferences." So,
well, Sue pays me royally.
We've actually done quite a number of virtual conferences with you recently, but we haven't talked specifically about the subject of infection control. And of course, you are one of the nation's leading experts on infection control and certainly handle all of the infection control monitoring and oversight for our company. And suffice to say, it's been a slightly busy time for you. Is my sarcasm flowing through?
No, you drip well. You drip very well. Lots of questions come in, I have to say, and I'll tell you, I even see it in the accreditation organization because they are forever monitoring the centers that are on schedule for surveys. So they're still doing surveys, as many of you out there are probably aware of.
Especially our clients who have every one of them has been surveyed in the last 2 months.
Right. And I was scheduled to do a survey earlier this month, out of state. And I had a colleague, I was working with a partner, and that partner was from in-state. So the center started to get kind of nervous because of, everything that's going on, understandably. And reached out to me and said, do you think it's okay if you still come? And I said, well, it's really up to you. You're the center. You're the one that's asking for the survey. This was obviously not a deemed status survey since I was able to speak with them.
Right.
And, as it turned out, they opted to not have me come. And my wonderful partner got to do the whole survey by himself, and a day and a half survey became a 2.5 day survey for him.
Wow.
So that'll teach you for living in the same state.
Well, we had a survey. One of our clients had a survey that was during a snowstorm. And again, she was very tight in terms of the staffing. And she, the second day, she tried to get a flight out earlier. So she did second day virtually. From the hotel room. So luckily she had seen everything the first day. The second day we just sat down and kind of went through all of the stuff you could talk about, and we could share screen and also, did the exit that way. It's very, very successful. I do wish that the surveyors would come up with some mechanisms now. I'm hearing that this is happening with Quad ASF and I believe Joint Commission is experimenting with it. I don't know that HHC is officially doing any of this, but I do think that if we could cut down the amount of time that's on site, do a lot of those things that can be done remotely. People like you and I, surveyors like you and I, we talk a lot, of course, or especially me. And a lot of those conversations can occur by a virtual session we're actually recording Laurie here in a virtual session, even though this is going to be a podcast. But I think we've proven that these things can be very successful.
They can. It's funny though. I don't want to consider myself scattered by any means, but
I'm just really trying to hold back, but go ahead.
But when I'm on a survey, it's almost like, when I make fun of you, shiny things.
Squirrel.
Yeah. As I'm walking down the hall, all of a sudden something pops in my head because I see something.
Yeah.
And so that's where the on-site is so valuable.
It is,
because I don't know about you, but I can probably fake it till I make it.
Yeah.
If I'm sitting in an office with a bunch of books and a computer and some wise people writing me notes to answer questions of a surveyor that isn't seeing all that. Does that make it wrong? No, as long as they have the right answers. But I don't think the center gets the value of the survey. I understand we're in different times right now, but I would imagine if we become too complacent, then we're going to find that we're not doing things to the best that we can. And that's the whole purpose of ambulatory surgery, is to provide the highest quality of care.
Yeah.
So if we get lax, then we're kind of not doing that.
Well, and I certainly don't intend to minimize the role of the on-site. I agree with you. I just think that on-site could be much more valuable if all we're doing there is walking around and witnessing firsthand what's happening. I think that in a time like this when the paperwork can be done in different ways, if I'm going to be on site, just let me walk around, let me meet people, let me talk. So we've been witnessing a lot of surveys. We've had one complaint survey. This is one of our centers that we have not been able to get down to that doesn't really hire us to do a heck of a lot of work for them. And they just had a complaint survey. And unfortunately, they did not fare very well. Didn't seem like they were following the protocols that we established for them, and very disappointed to see the results of that survey. But so we've been warning people, and we've been telling people that Santa Claus is watching all the time. He's keeping a list.
Surveyor on the shelf.
That's right, surveyor on the shelf.
We'll have to come up with one. We can set somewhere.
That's a great idea. So they showed up and found a lot of problems. And I'll tell you, the most disappointing thing is I found out that they weren't even screening people when they come in the door. I mean, the most basic things were not being done there. So keep an eye out, everyone. And it's, and by the way, don't tell me, I've said this over and over, don't tell me, well, don't worry, when the surveyors show up, we're going to do it right. But here's the point is this was a complaint survey. Clearly a patient must have been watching and didn't feel that they were doing a good job. Could have been an employee, actually, I don't know.
Or it could have been a staff member that felt like they weren't being able to do a good job.
Right. And so now the center's in quite a bit of trouble. Please, if you're listening to us, understand we're not making these rules up because we're trying to make your life miserable. We're making them up because they're for the health and safety of our patients, and they are watching. Our employees are watching. A big conversation I've had this last week, Laurie, has been this continuing conversation of what do we do in order to keep our staff from saying they don't want to come into work. So we know in New York City, the mayor kind of inferred that he was going to be shutting down the city for an unexplained period of time after the Christmas holidays. And we've been talking about how we doubt it's going to affect surgery centers from the standpoint of them not doing surgery. But I'm concerned that if they do the shutdown, that our volume is going to drop to near nothing because the patients are just not going to want to come. And probably more importantly, the employees are not
between if schools close or if transportation's an issue or anything like that. And I did want to say also with what you were talking about with the screening and everything, I wonder how much of it has to do with kind of the pandemic fatigue that we've talked about. I just want to remind everybody that these people are still watching, like you said, and you just gotta keep it up. It may be something you're always gonna have to do, at least for a very long period of time, regardless of the vaccine or anything.
Yeah. Let's talk about that for a second, Laura, because before we push the record button, we were talking about, what do you feel is not going to change? I mean, I think everybody, yes, we have this fatigue, and I think we're all hoping that things are going to go back to what everybody thinks is going to be a normal. But there's some things that I think we all believe are going to be permanent changes in the way we do business. Do you want to talk a little bit about some of that?
Well, I have a feeling that we're going to keep up with some form of social distancing. I do believe that in the healthcare realm, we're going to be limiting those that accompany a patient. And right now, we pretty much shut it down to 0 people, in extreme circumstances. I think maybe when we open the gates, it might be 1 person, truly. And if possible, nobody. I think we'll see that in retail as well. I think we'll still see the dividers up between cashiers and patrons. I think you will see it in restaurants with the dividers between tables for quite a while, if not maybe long lasting. Do I think masks will be forever? Gosh, I hope not.
I know.
But we might do it in healthcare. We might still require people to wear masks in healthcare. Maybe not so much at the grocery store, but for sure in a hospital or in our surgical centers where we're now focused on airborne infections. So, you figure the hospitals have been doing it for years for the employees that do not get the flu vaccines during flu season. So you figure from, I don't know, October through March or April. I have a feeling that that's going to be forever.
I agree.
So we'll all have a little thing at the front door, and everybody gets masks when they walk in.
And probably temperature monitoring certain times of the year, or there are these devices that you can purchase that automatically sense your temperature when you walk in.
And that may change a little bit too, to more of the regular screening, because as we're finding out, temperature isn't.
Yeah, right. That's true. But at least
it's a good thing to do. But and people, like you said, just being much more aware. Don't push through it and go to work if you're not feeling well. Yeah. Stay home and keep other people safe.
And that's something that's a long time coming. I can remember constantly sending employees home because they really thought that they were. Well, actually, I remember. I think we talked about this on the podcast too. That the old days was that crotchety old nurse who would come in. That would be you, Laurie, would come in and work because she was afraid that she was letting the rest of her staff members down.
I'm that crotchety old nurse. I'll tell you, I've done that. Was it right? No. Did you know it wasn't right? Not really, because it wasn't a stressed thing. But,
it has to come from the staff members as well as from leadership, because if you feel guilty and you feel like you're really, like, they're so short-staffed that it's going to affect everybody if you don't come in, it's kind of hard to put that all on you to just call in when you really don't want to.
Right. And, so that's tough. I mean, I think things like that. I think that we will screen closer with our pre-op calls, that sort of thing. But when it comes to the temperature monitoring, we do that with all our patients now. Yeah. We did it before. I mean, it was part of their, vital signs. But I do think we might continue that with our staffing. Maybe not with the visitors, but who knows? I mean, it's still, everything is in pencil, really. I mean,
Well, and this equipment that you might be purchasing, I know people have been picking up these iPad, I don't know if they actually are iPads, but they're iPad-like devices that you have in your entering way that checks your temperature when you walk in. The signs up front that ask you to, have you been here? If you have any of these symptoms, just turn around and leave.
The
more automated you can make it, the better.
Yeah.
And signs on the outside of the door saying, if you have this, don't even bother coming in the door because we're not going to treat you.
Right. Right. Yeah. So, I mean, and that's across the board. It's whether you're going to your primary care doctor, whether you're going for a mammogram, whether you're going for surgery. I mean, up here in Massachusetts, the governor has done another lockdown. Yeah. So, they've pretty much not so much froze, but they've, deterred, elective procedures in hospitals.
Yeah.
They have now, starting today, they've put more restrictions on restaurants, health clubs, and whatnot with the amount of people. They've gone back, I think, to like 25% maximum. They've cut back on the number of people that could be in social gatherings in public and in their homes, which I don't understand how, unless it's, your neighborhood watch is calling in if there's more than two cars there. But they've really gone back to that just because of the increase of cases. But, I think it's just the more people get tested, the more cases we have.
Yeah.
And does that mean we shouldn't get tested? No, it's just we need to realize that there's going to be a correlation between the two numbers.
Well, and that the other problem with that type of calculation too is it does, I think New York, for example, is 47th in terms of percentage of people that are, in other words, low in terms of percentage found to have COVID. whereas other states are much higher. But of course, New York is testing everybody, not only testing everybody, but testing everybody multiple times.
But see, they say that, and it's hard for us to get tested. So
I know, I don't know. But well, if you look at the sheer number of tests that are being done, it's very high compared to other states who are only testing people that are symptomatic.
And I think we get good information from that. But like you said, you just have to be aware of those numbers, what you're looking at.
Well, I hate it when people make the conclusion, well, New York is safer, because it's got a lower rate of infection than another state. That's really not necessarily true. Now, I mean,
safer job because everybody's leaving New York.
That's true. And with our new tax increases, we'll be the next ones out the door.
Yeah.
We're heading down to South Carolina, Sue and I, in February, and maybe we should be looking for a permanent location down there. We have to bring the whole family.
Yeah, not unless everybody.
I don't know. I'm ready. Get away from the snow. We have a nice fresh. Do you have snow up there in Massachusetts?
It's freezing, but look, we had the horrendous. I don't know if you guys did when I was in New York yesterday or Christmas Eve, Christmas Day. We had the terrible rainstorms and winds, and it was not fun. Driving home was worse than if it was snowing because of hydroplaning and stuff like that. But and then here in Massachusetts on the Cape, we had the high winds and the rains. I mean, the nice thing is our solar panels are very happy right now because there's nothing on them. It's like cha-ching, we got another nickel. But the snow's almost all gone.
Yeah.
A ton of snow, a week ago?
Well, we're shipping some your way. So we just got a nice little snowstorm last night. So it's on its way.
Not too much, though. But that's one good thing about working at home. And I'll say, I think that the next thing, and I hate to think of the next thing that might come down the line, but I think we're going to be so much more prepared because now I really think a lot of people there's going to be some form of working from home.
They're going to save a lot of money if they're not paying rent.
Yeah, I mean, like in New York City, that's what you were talking about. People that are having to, rent office space in New York City. Imagine the money that they can save.
Well, and we have a couple centers there that their business office staff are pretty much have been working remotely for almost a year now, and we need their space. We've already taken it mainly because it's storing, it's the storage location for all of our PPE for now. But can you imagine some of these really small centers that could use additional storage space, can use, another consultation room for patients when they come in prior to the surgery.
Yeah. Especially where you might need an isolation room or
week 40.
Is that really week 40? Oh, my goodness.
I was trying to think of some questions that we've had. And one thing we've been asked several times is, should they mandate the vaccine for their employees? I don't think so, but I didn't know if we wanted to have a
it's an interesting conversation. So we all have our opinions. Personally, I feel that you probably would have some type of a legal problem forcing that on patients anyway. So I don't think it's reason. I think it's a good question, but I'm not sure that we know what the answer is going to be. The question is, what are you going to do with those patients? Are those employees that don't take the staff? No. I mean, the obvious answer is, do what we do with the flu right now, which is you mask up. I don't know. What are your thoughts on that one, Laurie?
I think it's going to end up, you see all these different articles online, et cetera. I think it'll end up being similar to the flu. I do think that there has to be some restrictions or there has to be some cutouts for those that either have some sort of allergic reaction, a medical condition, because not everybody is, capable of getting the vaccine, depending on just because, you could still be working and have a medical condition, so there's that. And then of course there's, those that have different religious beliefs, so I think it'll end up being treated in that same manner. And perhaps those persons, yes, will be masked for a certain amount of time or might have to be masked 24/7. Because as we saw, this virus started in March. It's now December, so it doesn't have a favorite season.
True.
So it's not like the flu in that respect. So, those people might be masked the entire time they're at work. And they might have to have some other kind of screening, they might take it to the next step. I'm sure those that didn't get the flu vaccines, again, I'm not sure because I didn't work in the hospital, but I've always gotten the vaccine, would probably just have been wearing their masks because they didn't have a little thing on their name tag that said I've been vaccinated. But I don't know that they were screened for temperatures and things like that, but they will be going forward, I'm sure.
Yeah. Yeah, it's funny because that used to be enough to get most people to get the vaccine in the hospital because nobody wanted to wear the mask. Well, guess what?
Yeah, it's so true. It's very, very true.
Yeah. And that's actually a good, also, it may have to do with the prevalence in the community. I can see it kind of being a constant monitoring of, okay, anybody who is not vaccinated, the numbers are going up, whether it has to do with season or not. And having to wear the mask kind of like a declared COVID season or something.
Well, and I do think, here's a prediction on my part, is that I'm hoping that we're going to start seeing some changes in mask technology. Because, I'm wearing a KN95 now, which is a step up from a regular surgical mask because it does cover your mouth, doesn't it looks somewhat like an N95. Doesn't have the same rating and it doesn't hold. I mean, you don't have to be fit tested for it, et cetera. But it's certainly more protection than a regular mask will wear. The price is dropping. It's still about $1 each, $1.25 each, I think. But my prediction is that we're going to start seeing, people having access to better quality masks moving forward, and that we're all going to keep a stock of it, just like we have, socks. We're going to have our masks.
It's just a matter of which ones are more effective, and we don't.
Let's talk about.
Nobody's saying that they work 100%.
Let's talk about that for a second too, Laurie. Do you want to weigh in on gaiters and cloth masks?
I really think I want to get one just so that my neck is warm. Truthfully, but I think that.
The gaiters was what John's getting at. The gaiters have been said that they actually make the particles smaller as you're breathing out. So if you're around somebody who's wearing a gaiter, those cloth kind of things that pull up over, you're actually probably less safe. Yeah. So we wish people wouldn't.
And again, we're talking about people that are in the non-surgical areas. Yes. So this would be people that are going to be, first of all, patients too, coming in with one on, as well as our staff members, but that would be in a sterile area or non-clean area.
Right. I mean, the whole purpose of the mask is the filtration. So, you want the fit and you want the filtration. So a cloth mask is adequate, but the thing is, even with surgical masks, if they get wet, they're no longer doing their filtering. Yeah. That's why a lot of times they would have a time limit on masks years ago. You needed to change it after so long because it wasn't as effective as when you first started wearing it. So with a cloth mask, every time you exhale, a little more sputum comes out, and then your mask is getting wet, and now it's nice and warm. And so, you kind of have to put those things together. warm, dark, moist. Oh, that's a great environment to grow things. Yeah. So theoretically, your cloth mask is a nice little what are those?
Petri dish.
Breeding ground.
So I throw, if I have a couple cloth masks that I might wear like out to the grocery store or when I'm running in somewhere, I throw them in the laundry.
Yeah, exactly. Yeah. It's got to be cleaned regularly.
Yeah. But at least I'm cleaning them in my little brain here. I think I'm cleaning them. So the thing with the gaiters would be the same thing. And then you figure if you're wearing a gaiter, it's up and down and up and down and up and down. So
it's the whole design is for that. Yeah.
But like I said, I think it would keep me warm, especially up in this cold.
I actually saw in one of the online clothing stores that I used to shop at, they have a shirt that's sort of like a turtleneck, but you can pull it up and it has loops that go over your ears. I don't think it's that effective, but I thought, wow.
Now they start
so you're never caught without a mask.
If they start building filtration systems into it, we've got it made.
If a person's refusing to wear a mask, but they'll do that, all right, they're doing something.
That's right. Yeah. Well said.
Yeah. So, that's baby steps thing.
A question came up this last week, Laurie, and I'm throwing this out to you without giving you any fair warning about it. But one of my colleagues Actually, a friend of ours asked the question whether an EMS provider, like an EMT, can do the health assessment on an N95. And my immediate reaction was probably no. And then when I researched it, it was an emphatic no. So interesting development there is that when you look at the guidance from OSHA on the health assessment that has to be done on people that are being fit tested for N95s, it does have some information. And I don't want to spend a lot of time because it doesn't affect all of us here. But an RN is one of those individuals that can do that type of an assessment. Of course, a physician can do that assessment. But I just want to kind of briefly remind people that health assessment that has to be done as part of the N95 fit testing is extensive. I think the recommended form from OSHA is like 4 or 5 pages long.
Yeah, it is involved.
But it has to be done. Can't be done by your nursing aide. This is something that has to be done by somebody who can evaluate the results of it. And make some type of medical decision as to whether this patient is all right. But I know we try to avoid talking about N95s all the time. And it certainly is not our recommendation that everybody go out and fit test, or that we recommend you fit test people for N95s if you're using N95, but it is certainly not a requirement that you wear that, at least in most states right now.
And as we mentioned in our last one, too, about the over masks that can affect.
Oh, yeah. Let's just briefly talk about that. Is that in the past we've been giving advice based upon the best information that wearing a mask over the N95 would, first of all, help save it so that you can not have to replace it in between every procedure. But now we have guidance that's come out, and you assisted in that process through ARN. Do you want to talk a little bit about that, since you're the one that kind of provided us that information?
So in my spare time, I was listening to an ARN webinar, and it was put on. It was about respiratory protection, and there was a gentleman on it, regarding a type of mask that his company was doing. But in the process, they had mentioned that it is recommended that with an N95 or any surgical mask, that you don't put a mask over it. You could use the shield as the second layer, a face shield. And the rationale behind that was because putting a mask over your mask, whether it's an N95 or a surgical mask or whatever, could change the fit on your face. So when I heard that, I was like, whoa, wait a minute. And so I tried to write in a question and I couldn't. So I called them on their question line that they have a couple days a week to get it clarified, because I went on the OSHA site and OSHA says to wear a mask over your mask.
Oh, really? I didn't know that.
So here I am on the phone with, my gods of AORN, and I had them pull up the site I was looking at, which was the most recent site. And they said, no, they said, oh my gosh, thanks for pointing that out. But no, we stand behind that you don't wear a mask over it. And 3M, who is the main maker of the N95, also is the one that says do not put a mask over it. And it's all about the fit, because now you're kind of
pushing it in. Yeah.
Making up, moving the mask around. So I found that very interesting, and it's like, oh my God, I've been so rude to all of you people out there in radio land.
Well, so let's remind everyone that the issue there then becomes, if you don't have a face shield, if you're not wearing a mask over it, that means the N95, when you're in a surgical setting, is going to have to be replaced in between every single procedure, which will probably pretty much knock out everybody from using an N95, on a procedural basis, unless they have those masks. Now, I wore one of those. We did a survey this last week, and I wore one of those masks the entire time. Man, is that different. First of all, I couldn't hear anybody, but I could certainly hear myself well because of the vibration back of the noise. But my hearing isn't fantastic as it is, I think. And now you put one of those things on, and it distorts everything out there, right?
I even find the fit of the N95 it's just so it does a great job. It's just so tight.
Yeah.
That just bothers me. Of course, it ruins my hair. But, it's just like, oh boy, so getting used to that is tough. But the whole point is it's what's the safest that you can do for yourself. And if your employer provides it and you're in that procedure room or that operating room where there is that higher risk of contamination, then, again, it's your choice unless they're forcing you to wear the N95. But, it's something that you really have to think about. Now, I'm having flight of ideas again. And
here we go.
Oh, yeah, the squirrel. It'll come back, because there was something that I wanted to point out, but whatever. It'll fly in.
Well, I think it is important that you really very carefully consider your N95 program. One of the points that I've made to people is that there are no real regulations that require people to wear the N95. Often the reason that we have it is because the employees feel safer with it, or that might be the reason they're coming back to work. We've had situations where the anesthesiologists have said, we're not going to work at your center unless you provide us with N95 masks. Sounds like you remembered what you were going to say.
I did. I saw it go right across the screen when you said program. So back in the beginning of COVID time, when we all ran out, or when many centers ran out and got their N95 masks, it was polite that we kind of got a waiver when it came to the fit testing and whatnot, because it was something that we didn't normally do, and we were having trouble finding ways to get it. So it was almost like we got grandfathered a little, the ASCs, when it came to the actual fit test for the N95 and the assessment. Mm-hmm. Well, that's not the case anymore, people.
Right.
Like we said, it's been 40 weeks. So there's been ample opportunity. So the whole purpose when this all came out and we all had to have that respiratory protection program for our centers was that the intent is that we do that on an annual basis.
Yeah.
We had to show that in good faith we had attempted. Well, it's now 9 months. So you better have hopefully done that good faith and gone out and now have performed that for your staff members.
Right, exactly.
Because if OSHA comes in, they're going to expect that. And who knows, you might have a surveyor that's privy to that information and is going to ask you, well, why haven't you done it? You've had more than enough time to get this done. You're not doing the service to your staff that you're supposed to.
Let's talk for a second about OSHA there, because unlike surveyors, and in most states, even the state surveyors don't have the ability to fine you for not complying with the regulations. The only thing that AAHC and Joint Commission and Quad ASF and those other surveyors can do is report to CMS, and CMS can take your license away. But there's usually not from a federal standpoint, there is no fine associated with. Some of the states do levy fines, but OSHA can and does. And these fines are not small potatoes. They're 5-figure at least, sometimes 6 figures, depending upon the size of the organization, the size of the violation. So again, failure to follow those OSHA guidelines can result in a substantial financial hit to the organization. And we know that surveyors are out there from OSHA that are looking around for this, because OSHA's always had a very strong program for inspections. They just haven't spent a lot of time, certainly very little time in surgery centers in the past, not as a lot of time in hospitals, but you can bet that that's their new hotspot. That's what they're going to be spending a lot of their resources now, inspecting our locations.
Right. And when you think about it, we're out there banging the drum saying that we're a safe environment, that we can perform those surgeries that are not being done in the hospital right now due to the increase of, COVID patients and the need to be able to service them accordingly. So who else would OSHA want to look at if we're the ones that are doing those surgeries now? And obviously, you're still going to have some possible rift between hospitals and surgical centers, and the hospitals might feel that, yes, we're taking their cases from them that they can't do anyway.
Yeah.
Whistleblowers are everywhere.
Yeah.
I mean, they're everywhere. It's not like Sue said, the surveyor on the shelf. It doesn't take much. And so, we have to really be on our A game, even more so than we always were. Because it's almost like reinventing ourselves now.
And to that point, we have to recognize that the very fact that we are doing all of these precautions, and the more we make a big deal out of it, will help us down the road when we're trying to convince patients to come back to us. Patients they're going to know, and they're watching us, and they want to know that they're going to a safe environment. I want to know, I don't go to grocery stores anymore. We have all the food delivered because I know it's certainly a lot less safe in a grocery store than it is in one of our surgery centers. People don't necessarily want to go to hospitals anymore unless they absolutely have to, because that's where, unfortunately, the COVID patients have to go. So if we can avoid that, if we can make our patients feel safer because we're taking all these precautions and then advertising that, we're likely to be able to stay open longer. Laurie, can you talk a little bit about what precautions? We really haven't actually gotten to the important question here is what should we be doing now? What are some of the new changes that we're doing with regard to ongoing cleanliness? And let's talk about environmental cleaning, for example. And I'm making the presumption now that this is permanent too, that, that extra person that you hired in order to do that cleaning, don't lay them off at the end of the year, that they're going to be part of your organization forever. So talk a little bit about how environmental cleaning has changed, how it's most likely going to be permanent or not. Tell me if I'm wrong, but go ahead.
No, I do think it'll be permanent. So, dial back a year and our patients would come in, and some of us had changing rooms, and we might have had lockers, and, the patients were assigned, given their gown and whatnot and given a locker, and they would put their clothes in the locker. And then at the end of the case, someone would get their stuff out of the locker, bring it to the bedside, they'd get dressed. And then meanwhile, now someone else went in the locker. A lot of places, and, maybe I'm wrong, but in my heart, I know I'm not, didn't clean the lockers till the end of the day. Right? So that might have been part of either the end of the day cleanup, or it could have been part of your environmental service company that came in, they clean the lockers. Now, we should be cleaning them between every patient. Just, it's just when you sit back, it's like, well, gee, that makes a lot of sense now, doesn't it?
Yeah.
But it was something else that it wasn't in our wheelhouse. We weren't even thinking about that, that someone's shirt and pants and coat and underwear and whatnot are just sitting on the shelf in there, and the next person's shirt and pants and underwear, et cetera, and, it's all surface. So you figure we are contaminating everything that we walk by. So, there's just that. So if you have 30 patients a day, and you have, say, 10 lockers or whatever, you're turning over those lockers constantly. You're cleaning the restroom in the waiting area way more than you should be, way more than you were before. The only time you clean the restroom usually was if a patient or a family member came out and said, oh, you know what, there's something wrong in the bathroom. I think it needs to be looked at. And that's usually how you found out. Because staff aren't going in those bathrooms.
Right.
We're not thinking about that. The CDC recommends that things get cleaned. The other day I was at a place I had to go for my mammogram, and they had signs up that they clean every, it said every 3 hours due to the CDC recommendations. Truthfully, I haven't looked at it to see if that's true. But, the fact is they were advertising that they're doing that. And sure enough, while I was there, someone came in and was cleaning the two little changing areas, wiping down the handles on the lockers. They weren't even using the lockers, but the staff would open the locker to get your gown out. So, and now they have you carrying your bag of clothes with you everywhere you go. Yeah. So it's just things like that. Never mind, the doorknobs, the phones that, we might have cleaned them if we knew somebody had a cold and sitting at the desk and using the phone, and then we went to use the phone, we might wipe it down. Well, no, now we're doing it constantly, or should be doing it constantly. So no, there's an awful lot of extra wiping, extra cleaning that's going on that you can't always, the nurses don't always have the time for. So as you said, John, you might have hired someone new, or you might have had an aide that would help with other things. Well, now they're running double time, and you know what? They're tired too. So it's just, we can't overlook that part anymore. Keeping our offices neater, tidier, whatever,
What does raise an interesting question is many organizations, hire an outside cleaning service to come in because it's more cost effective, or in the past have been more cost effective for this. And the main reason for that is because they could do the cleaning after hours as opposed to doing it during, regular working hours. Number of years ago when the last surgery center I built before I did what I'm doing now full time, I was so frustrated with the number of times I had to change cleaning services. I ended up hiring somebody to do the cleaning, bought all the equipment that I needed to do all the cleaning, and we had a wonderful program there because, first of all, we had total control over the cleaning. The person would start later in the day so that he would go into the evening hours so that we're still doing that, cleaning that needed to be done when nobody was there. And it worked out very well. And it was actually very cost effective. Over the years, to our clients, I've recommended when they run into the same challenge that I've had here, especially when they're very upset about the quality of the cleaning, to consider doing this. So I would personally, this is just my own recommendation, is certainly look into it, especially if you already have hired somebody now to do the extra cleaning. Hiring somebody in addition, or a part-time person to supplement that, can take you from a situation where you're hiring an outside cleaning company who you have to supervise anyway, who you have to train anyway in how to clean in your organization. By the way, if you're not doing that, all of those outside cleaning companies, I don't know if we've ever mentioned this before, they need to go through OSHA training. They need to demonstrate to you that they've gone through both OSHA and OSHA bloodborne pathogen training. And if they have not, then you have to provide that training to them. And the first day before they start working there, every new employee, which, by the way, in some of these cleaning companies could be every week, has to be trained on cleaning in your organization. They have to know the equipment, the supplies that are available there, and they need to be supervised. They can't just be, thrown into that organization. So my conclusion after, thinking this thing through and realizing the higher level of cleaning, just like you said, that people are just constantly doing it throughout the day, maybe it's time to chuck the cleaning company and then bring it fully in-house. I don't know what your thoughts are on that.
Well, and the other thing too is that, you have to, hopefully that they're using the products that you have recommended,
right.
That they're using them the way that the manufacturers intended them to use them.
Right.
That they're not just bringing in, oven cleaner because they know it gets the grime off the silver stuff.
What's that stuff that our cleaning person uses, Sue, that we found in one of the surgery centers where they were using? Fabuloso. Yeah. No, not being critical about Fabuloso. However, it is not an appropriate cleaning product in a surgery center.
Yeah. And then, the other thing too is it's usually the surveyors that'll find out unless you're really very up on top of everything because you have nothing else to do in your surgical center. When you go into the closet, where the cleaning supplies are, and they have them all put out into their different containers that aren't labeled. I love that.
It's a lot of documentation that we have to send back to the accrediting organization, but yeah,
exactly.
They're in trouble now.
That turns out to be an OSHA violation.
Yeah, true.
So that's a double whammy. So it's just things like that. And if it's, and I'm not saying cleaning companies don't have pride, because they do. Mm-hmm. I mean, when people work hard, they're proud of what it is that they do. But the other thing too is if you did have someone in-house, if you were fortunate enough or to be able to hire your own cleaning crew and whatnot, then they're there all, they're with your staff. They're mm-hmm. working with you. they see the results. They hear the patients say, wow, this is really clean, or things like that. And then they have, that's a sense of pride for them. And it's a sense of pride for you, the center, that, that it's noticed and that you appreciate the person that's there. I think. But yeah, most of it is after hours, but there's a lot being done now right in front of us that, there's one center that the nurse goes and gets the patient from the waiting area, brings them back, but they change in the bathroom. Then they have them on the stretcher. They're looking over their permit or whatever. And the nurse is running into the bathroom to clean the bathroom after the patient changed in there.
Yeah.
Do I think that's smart? No.
Yeah.
Do I think that bathroom's getting cleaned appropriately? No.
Probably not.
I mean, it's
she doesn't have the time. She doesn't have the time to do it absolutely right. She's doing it as quickly as she can because she's got to get back to take care of the patient, which is her real job. So
and the fact then is that now the doctor's tapping their toes because it's taking you longer to admit the patient.
Yeah.
Is that a wise use of personnel? Definitely not. And there's that patient sitting there going, okay, well, she just kind of left me here, or he left me here. And, so it's sometimes things, we don't always think we're going to save a nickel. Well, no, you're going to really end up costing you more in the long run.
Well, and the advantages of having it in-house also, they can help with turnover. All of those other cleaning functions that your staff is doing now, which is, as you said, have become much more difficult during this time. You could push off on other individuals. And it's great to have that person cleaning throughout the day. So you can see that. The patients can see that. Your staff can see that. They're going to feel safer.
Yeah. Yeah. No, and it's true. And the more time you as a caregiver spend at the bedside, the safer the patient feels.
So I guess now we should talk about vaccine. And we're recording on December 26th. The vaccine has been out for about 2 weeks now. The second vaccine has started shipping also. A daily question we're getting from our clients is, should I apply for getting the vaccine? I will tell you that our general concern is that the responsibility that you take in becoming a vaccination site, even if it's just for your employees, I think is massive. Laurie, you've been doing a lot of research for our clients on what needs to be done as part of this. And can you just talk a little bit about the challenges of being a site that administers vaccines before people decide whether they're going to actually get the vaccine themselves?
Well, you really have to do your homework. Each center needs to do their homework and find out what vaccine will be available to them.
Mm-hmm.
Okay. So then, all right, that's great. Now I think you want to get a consensus of your staff of who's willing to get it.
Right.
So now you kind of have an idea of how many doses you need. Great. Now you need to find out the vaccine that you are able to get or possibly able to get. What are the restrictions that it has when it comes to the amount that you can receive?
Yeah.
Is there storage restrictions?
Such as the Pfizer one, which requires very low temperatures. Yeah.
So are you able to keep it at that below zero temperature? If not, I believe it has a 5-day shelf life at regular temperature. But again, you have to read the manufacturers. You have to understand what the manufacturer's telling you. And then, all right, so let's pretend there's a 5-day window that you can keep it in your regular medication refrigerator. Are you truly monitoring it 24/7?
Yeah.
So this is.
And are you using one of those dorm room refrigerators that I see all over the place, but are totally inappropriate for vaccine storage? Actually, they're inappropriate for any medication storage.
Yeah. So you got to think about that because now, this vaccine is brand new. We don't know the total ramifications it can have on us. And if we in any way have tampered with it, how liable are we?
Right.
If you have a pharmacy consultant, get them on board with this, talk to them, get their opinion and have them do it's almost like you have to do a risk assessment.
Mm-hmm.
Are you able to do it? Now, the other thing is, all right, what are the side effects of the vaccine? Potential side effects of the vaccine. So does that mean everybody gets lined up and gets shot all on Monday, and then they're all out on Wednesday and Thursday because of side effects? Do you stagger them, throughout the week, especially if you have a 5-day window to give the vaccine? Are there any medical conditions that these your staff members have that would warrant that they shouldn't get the vaccine? There's a lot that goes on with this. Are you capable of making that decision?
Yeah.
So, and then if you do the Pfizer one, are you ready to do this again in a month?
That's right. Well, both of them require a revaccination. So the two that are out there as of December 26th right now require revaccination. And you're right. And you got to be, and then you got to follow up with those patients or your employees to kind of hound them to get that vaccination on that second date. And now you're suddenly taking on a responsibility that usually primary care physicians and hospitals have. Yeah.
Or if you're having high turnover right now, there's what do you do if somebody leaves?
Yeah, what happens if somebody leaves between the two vaccinations?
And reporting, what are the reporting requirements that go along once you receive the vaccine? So there's all that. Now, do you have to designate who in your center is worthy of the vaccine?
And how are you going to avoid the family members of those employees wanting to come in and get their vaccinations too? There's a lot of ethical issues in my view on this too.
Definitely. And the thing is, all right, if it's for frontline workers and healthcare workers, what happens to the poor person sitting at the front desk?
Yeah. Right.
Are they not allowed to get it, or your billing person, or, so you need to, you please do your homework, find out what is required. So, I don't care what state you're in, you have to know what your state or even your county is telling you, because, within our states, we have different rules. I'm sure that in New York, the governor and the mayor might have different opinions. I know in Massachusetts, they do. So it's just things like that. You have to be doing your homework. But again, please talk to your pharmacy consultant. Have him or her give their opinion as well.
And let's talk just for a second about a couple things that if you are going to do the vaccinations, you're going to need to have a vaccination program, written program that outlines how you're going to handle the medications, how you're going to administer the various questions that have to be asked, the availability of the information that you provide to the patients, logging of the storage of the vaccine, and then there is a form that you should be using as part of your vaccination program that documents how you have administered that vaccine to your employees and who you administered it to.
Right. So the vaccine inventory log that Sue created, when you receive the vaccine, what you should do, based on the requirements and stuff, is you want the date and time you received it, the name of the vaccine, kind of makes sense, the manufacturer of the vaccine, how it was packaged. Did it come in single dose vials, multi-dose vials, pre-filled syringes, that sort of thing. The condition on arrival, was the package, in excellent condition, acceptable, or damaged. Now remember, if you get damaged vaccines, you should be returning those. You don't want to open up that can of peas that has a dent in it, because they could be compromised. The lot number of the vaccine, the number of doses that would be, that you received, and the expiration date that would be on the vial, and then the staff initials who received it. But remember, once you pop the top of your vial, it's only good for X number of days, depending on the manufacturer's instructions, or it could be the 28-day rule.
Which is the default rule, yeah. Overall.
And then what you're going to do is you're going to put the date that you administered the vaccine and the time you administered. You're going to just verify that you checked the expiration date. You're going to then, how many doses are left. So it's almost kind of like, think about when you have your narcotics and you're pouring out of your codeine elixir bottle, so you're keeping your tabs of how many mLs you've removed.
Yeah, because there is a requirement that you at least do a weekly. I think CDC says a weekly check, but this way you're probably giving all these doses in a fairly short amount of time. So if you're just keeping a running total as you're giving it, that more than meets that requirement, I would think.
And then put the initials of the person that you gave it to, and also the initials of the person that gave it. Obviously you're going to fill out the paperwork that will go in your employee files regarding the vaccine itself. But this will give you a quick look at if all of a sudden you find that lot number got recalled or whatnot. Now you have it all in one place instead of pulling out 27 employee files to see which lot number they got. It's an internal form that you're using. It's secured, and you're not giving out any information just by having initials on it.
I guess we should remind everybody that under USP 797, this is a multi-dose vial. Any of these flu vaccines, so they need to be drawn up outside of the patient care area, which in this case would be the patient care area would be wherever you would administer that medication to your own employee. So,
yeah.
Okay, Laurie, thank you for your time. This has been a very wide range conversation, a plethora of information. So I deeply appreciate your time. This won't be the last time you're on, probably last time this year. And just for our audience too, is Laurie and I are trying to fit in sometime in January a couple hour infection control seminar, I guess we would call it. That would be used for training your staff, like providing in-service education for your staff as well as for your infection control coordinator. And Laurie, let's give a push for CAPE.
Ooh, push. Well, CAPE is the exam for certification for ambulatory infection prevention. So it's specific to the ASC world. As opposed to the CIC, which is, like the godfather of infection control. So it's a little more, it's definitely more palatable for us in our arena. So it's been around, I think, 2 years now. And it's a great tool to use for understanding infection control. It also gives you a lot of credibility in your center if you have someone that is certified in infection control, because, as you know, you should have someone designated in-house that oversees your infection control plan. Some states require that you have a certified infection control expert as a consultant or on staff as well. So I believe John is working hard to push that the CAPE credential would suffice that, where it's pretty new. It's hard to get people on the right side of the law, so to say, but it's great. And the thing with the once you have the credential, though, you need to maintain it. There's a lot that goes along with it, for keeping up your credits and whatnot. John made me take the test.
And she passed it on the first try.
You almost did it for the oldest person. Great. It sounded like my mother. You almost failed your nursing exams. Oh, thanks, Mom.
Well, so for more information about CAPE, go to aboutcape.org, which is aboutcaip.org. And Laurie, I believe you're doing a training session on it in February with ASCA, correct?
Yeah, ASCA ASCA is putting on a program, a 2-day program on infection prevention. It will also help those of you that are thinking of becoming CAPE certified, study for the exam. But it's also out there for all infection prevention, so it's like a twofold type of thing. And yeah, I gotta work on that. So there's a number of us that are going to be presenting. I don't know if it's February 1st and 2nd or 3rd and 4th. It's a Monday, Tuesday in February.
Okay.
But please go on the ASCA website if you're interested. And the way I look at it is, if you love infection control, It's great. If you feel that it's something that you should know, for sure, you really should know it. Especially now in the world that we're in right now, you can't know enough on infection control. It's constantly changing. I always appreciate the input from all of you guys out there when you have questions and you challenge me. And, it doesn't take much to challenge me. But
No comment.
But I'm always learning. I mean, and like those poor people at AORN are like, oh my God, it's her again. They must see when my phone number comes through. They're like, all right, whose turn is it?
To answer Laurie's questions.
Yeah. I mean, and they're a great source. They're big on infection prevention as well. I mean, I don't care where you are. SG&A is big on infection prevention. The ASPAN. It's a vital part of our world now. That when we first were nurses or clinicians, we never really thought about it because somebody else was doing it.
Yeah.
And now we're the ones that are doing it. So I say, please consider it. If you don't pass, okay, just don't tell anybody you're taking it. Me, you pretend.
And Laurie, I do want to mention too that we still have available your infection preventionist program. Go to the ASCpodcast.com website. You can rent it, get a certificate at the end of the program demonstrating that you watched it, and that will help demonstrate to your surveyors that you have been trained on ASC infection control program creation. And we'll probably repeat that. Well, we will repeat that program live again sometime in the spring when we find time to do that.
And the thing is too, if people that are listening, if you have questions or there's topics you would really like to have addressed, tell John.
We're not being sarcastic. Yeah. Just send us information.
And he'll let me know because I'd rather us talk about things that you want to hear about instead of things that we think you might want to hear about. But I'm good at making things up.
Well, Sue is actually, of all people, Sue has been pushing recently to do a live podcast where we would have that, question and answer period. I think that's a great idea. We just haven't had it takes a little bit of organizing to do it. But I agree, Sue, that we need to, open up the lines and ask people what really is bothering them. So, if you have any questions, please send them.
There's no foolish questions. And God knows anyone that's listened to us before knows that I don't have all the answers. And, I've jumped up from the desk and grabbed books while we're live, because please, my head is so full of cobwebs that I don't have room to put knowledge in there. But it's great. And I think that the more we know, the more dangerous we are, but also the better prepared we are, just like this whole thing with COVID, we all jumped on, to keep everybody safe. And that's I applaud every center out there for doing their part and not crawling under a rock and giving up because, that's so much easier to do. But you met the challenges and they're still there and they're never going away now.
Right.
They're never going away.
And on that depressing note.
Thank you.
But thank you. As always, Laurie, thanks so much for taking this Saturday after Christmas when we probably could be doing other things, though I'm not sure what we would be doing now. And I really deeply appreciate your time and we'll bring you back. Maybe we should have you back every month. How's that?
Oh, you just tell me and I'll be there.
I know.
Your wish is my command. Oh, God, Sue just ran out of the room getting sick.
So, again, thank you so much. And you have a great remaining Christmas holiday.
Yeah, you guys too. Take care. Bye.
Bye.
Bye. In this segment, we discuss other learning opportunities in the ASC industry. If you would like your event to be included in the podcast, please send the event information to info@ascpodcast.com.
Now, those of you that have been listening to the podcast for a long time note that we have changed the words in this, because we used to say you are never alone in the ASC industry, and I think all of us can say we're starting to feel very alone lately because we can't go out to these conferences. So, but it is important that we keep you up to date with what is going on, even if it is virtual right now, and what's available too on the ASCPodcast.com website. So
the ASC Association's Winter Seminar is now a virtual conference. That will be January 11th, 19th, and 25th. This popular seminar, which is now a virtual event, as I mentioned, provides essential training for ASC billers and coders. During 3 afternoons in January, you'll hear from industry experts as they discuss the coding and billing updates for 2021 and share strategies you can use to maximize your ASC's reimbursements.
And ASCA 2021 is also virtual this year. So instead of just like in 2020, they've had to go virtual. And this will be held on 3 days, April 26th, May 3rd, and May 10th. And I believe those are, I can't remember what day of the week it is, but they are a week separated. The same content that they do for the annual conference will be delivered virtually. Then they have said that they want to get back to in person soon. Now, I'm on the education committee, and we have had quite a number of conversations about this, but I have still not seen an agenda. And I know I'm speaking. I got to admit, I can't even remember what I'm speaking about. So hopefully that agenda will come out soon, and we'll be able to give more information about what's going to be available.
Mm-hmm. And the 2021 Virtual Infection Prevention for ASCs seminar is February 1st and 2nd. And Laurie will be one of the speakers.
Absolutely.
Get the resources you need to develop and maintain an infection prevention program that protects your patients and your ASC. This course, which is comprised of 2 4-hour days, will also help you prepare for the Certified Ambulatory Infection Preventionist, or CAPE, exam.
And the 2021 Virtual Management Essentials for ASC Administrators Seminar is March 1st and 2nd. And the former name for this was the CASC Review course, by the way. So the CASC Review course has changed its name, a little bit of the content, too, into the 2021 Virtual Management Essentials for ASC Administrators Seminar, a little bit longer. And I'm one of the speakers. I'll be doing the financial section of this. As I said, it's March 1st and 2nd. So ASC leaders must be well informed and prepared to meet all the applicable federal regulatory requirements and accrediting organizational standards. Hear from expert faculty with extensive experience in ASC management as they discuss what ASC leaders need to know about compliance, finance, and quality management.
And the credentialing workshop that we recorded live on December 8th is available by going to the ASC Podcast website at ascpodcast.com.
And we are getting a number of people that signed up afterwards. Yeah, a lot of people that attended it, but it was a very well-received workshop. Mm-hmm. It's really, a seminar, I guess, is the term that we use for it. And it provides, it's really designed more for people that are in the weeds in credentialing. Mm-hmm. So, use it to train your credentialing coordinator on how to do proper credentialing. And administrators need to have it too, so that they know what their credentialing coordinator is doing.
Mm-hmm.
And, of course, probably the most exciting thing that's been going on is the Administrators Bootcamp. I can't believe it's only about 3 weeks away. Prepare for the challenges of ASC administration by participating in the ASC Administrators Bootcamp. And there is only 1 slot left in the winter cohort. So another one is scheduled for July, and more information will come out after this one is done. And also, we are going to be working on another Administrators Bootcamp program that'll be more virtual. In other words, instead of including a live section, it'll be a mentored program with recording. So that'll be available throughout the year. So there'll be a couple different options available for administrators depending upon the way in which they want the material to be delivered. The bootcamp includes reading materials, virtual private consultations with myself, and an intensive 4-day virtual conference presented in January 2021 from January 26th to the 29th. The program is really designed for new administrators that wish to enhance their skills, and administrators that wish to prepare for certification. The ASC Administrators Bootcamp is the industry's most comprehensive preparation for the role of an ASC administrator. So, and we are working to try to find a way to make this really available year-round, as I said. So more information, go to ascpodcast.com. Sue, we forgot to mention that if you're interested in all those things at ASCA, go to the ascassociation.org website. I can't believe it's not in the script there. And, please, we always want to encourage people to become a patron member of the podcast. Patron members, also known as ASC Central, is an exclusive membership website that provides a one-stop ASC regulatory and accreditation, compliance, operations, and financial management resource for busy administrators, nurse managers, and business office managers. Resources include some of our virtual conferences, links to important websites, policies and procedures, forms, drill kits, example drills that you can perform, discounts and services and books, and access to AEU credits on a quarterly basis. Membership fees help to defray the cost of producing the podcast, which seems to be growing every day as we wear out our equipment here, including our research staff, travel costs when we actually do travel, now equipment costs and production costs. For more information, you may visit asc-central.com or go to ascpodcast.com and follow the links for becoming a member. So that's it for this episode of the ASC Podcast with John Goehle. Join us again, please, and consider becoming a patron by going to our website at ascpodcast.com and spread the word about our podcast with your friends and colleagues, and do us the honor of hitting the subscribe button. The sound editor for this episode is Susan Cronkite. Executive producer is John Goehle. Research assistance is provided by Susan Cronkite, Jenna Alvarez, Judy D'Ambrosio, Alex Borneman, Zach Calritis, and Laurie Roderiques. Music is provided by Media Sushi and Mike Noah, and the ASC Podcast with John Goehle is hosted on Podbean and is available on all major podcast channels.
This podcast is an educational and operational tool and is not intended to be a comprehensive resource for all rules, regulations, and standards that an ambulatory surgery center must meet. The advice provided should not be considered as, nor does it constitute, legal advice or opinion. When reviewing specific situations involving legal and regulatory issues, attorneys and other professionals should be consulted. This has been a production of Eden Group Development. All rights are reserved. We would like to thank our sponsors: Ambulatory Healthcare Strategies, Surgical Information Systems, Encompass Healthcare Data Solutions, BHG Patient Lending, Medicus IT, and Intalere. For more information about our sponsors, visit our website at ascpodcast.com. If you're interested in advertising or sponsoring the ASC Podcast with John Goehle, please email us at info@ascpodcast.com. We would love to hear your questions and comments. Please email us at comments@ascpodcast.com.